A pleasant day to everyone, and a big congratulations to the Philippine Heart Association for the holding of this mid-year convention and the American College of Cardiology Extended Scientific Summit. These are my disclosures, and I would like to take this chance to greet everyone a happy new year. We look with hope towards a better and safer 2021. Indeed, perhaps there's no other word that trended on social media during the new year than one in which everyone is really wanting this year's theme to be, and that is the word hope. Everyone is hopeful that the pandemic will soon end and we soon will be able to get back to our normal or near normal or new normal lives. And even as we continue to navigate through this crisis, many of us have a feeling of expectation and desire for better things to happen. We have an optimistic state of mind with expectations of better outcomes for our family, country, and the world as a whole. We want to expect with confidence that it will be a better year than last year. And of course, we just put our trust in the Lord. These are the four keywords: expectation, positivity, confidence, and trust. That for me really sums up what this year will be about. And these are also the key issues that come into play when we deal with the topic of this talk. How do we manage the patient with atrial fibrillation and acute coronary syndrome? We have to know what to expect. We need to work for the best positive outcomes. We need to be confident with our treatment cocktail. And we just have to trust the evidence and the guidelines, but at the same time, individualizing our regimen for our particular patient. What do we know about atrial fibrillation? It is a common heart rhythm disorder, and it is estimated that 25% of the population will have this particular arrhythmia at some point in their time. And it is a result of multiple cardiovascular risk factors, but what is consistent is its association with an increased risk for stroke, with about 1 of every 5 strokes being secondary to this condition. And these types of strokes, the cardioembolic ones, are more severe and associated with higher mortality and more functional neurologic disability. Coronary artery disease is a common comorbidity in atrial fibrillation by virtue of its shared risk factors such as obesity, diabetes, and hypertension. About 15 to 20% of these patients at some point in time will have an indication for intervention such as angioplasty and stenting because of an acute coronary syndrome. But unfortunately, the combination of the two conditions leads to poorer outcomes. On the other hand, among patients presenting with acute coronary syndrome, about 10 to 20% of them have concomitant atrial fibrillation or will develop atrial fibrillation. ACS itself increases the risk of new onset AF. And AF per se is linked to an increased risk of acute coronary syndrome. And the combination leads to a higher stroke rate and mortality. Now, the interesting drawback is that patients are less likely to receive the recommended antithrombotic treatment, which further complicates the picture. Science tells us that the thrombus formation in AF involves the coagulation cascade and multiple factors such as inflammation, endothelial injury, anatomic structural abnormality, and hypercoagulability, comprising your so-called virtuous triad. Evidence has shown that your antiplatelets, in fact, confer small protection, and that warfarin is superior to aspirin in terms of stroke reduction, but is associated with more bleeding. On the other hand, your non-vitamin K oral anticoagulants, or NOACs, which emerged in the last 11 years, have been shown to be equivalent or superior to warfarin in decreasing stroke, and most of all, significantly reducing intracranial hemorrhage and major bleeding. And we are backed up by 4 landmark trials that revolutionized the role of NOACs in stroke prevention and atrial fibrillation, covering more than 70,000 patients versus warfarin, showing in general superior or equivalent reduction of stroke and systemic embolism, equivalent or superior reduction in mortality, and most of all, superior reduction in major bleeding and intracranial hemorrhage. Now, the guidelines of both the European Society of Cardiology and your American College of Cardiology dictate the use of warfarin for patients falling into this category type 1, those with moderate to severe mitral stenosis and those with prosthetic heart valves. For other patients, we stratify using this CHADS VAS score, looking at the age, the presence of heart failure, diabetes, previous stroke, vascular disease, and gender, with the consensus that male patients with a score of 2 and female patients with a score of 3 will warrant anticoagulation, preferably a NOAC, because of their superior efficacy and safety compared to warfarin. On the other hand, the thrombogenesis in acute coronary syndrome involves an interplay of platelet activation, inflammation, factors such as your atheromatous plaque rupture, inciting a cascade of atherothrombotic processes. In ACS, dual antiplatelet treatment with your aspirin and a P2Y12 inhibitor remains the cornerstone of treatment, with association with it better outcomes, lesser myocardial infarction, stent thrombosis, and mortality. In patients presenting as ST segment elevation myocardial infarction or high-risk non-ST segment elevation acute coronary syndrome, percutaneous coronary intervention, or your PCI, is part of the management. And these patients undergoing intervention, the dreaded complication that needs to be prevented is stent thrombosis, in which the greatest risk is at 4 to 6 weeks. Now, the combination of the two results in a highly complicated milieu, because on one hand, we need to deal with the stroke risk in atrial fibrillation, for which an anticoagulant is indicated, and on the other hand, we need to address the thrombotic and ischemic risk in acute coronary syndrome, especially those undergoing PCI, for which dual antiplatelets are recommended. Conventionally, this should involve the combination of an anticoagulant and the two antiplatelets, or what is termed as your triple therapy regimen, which obviously is associated with more risk of bleeding. The management will now be a more difficult balancing act of addressing the risk of thrombotic events, which will include your recurrent stroke, myocardial infarction, and stent thrombosis, and the risk of bleeding. And really, this is where our mandate as physicians will be truly tested. An extreme challenge to our Hippocratic oath to do no harm or do the least possible harm. The rationale is that dual antiplatelets are needed to prevent stent thrombosis, but insufficient to prevent stroke. While anticoagulants, on the other hand, will be needed to prevent stroke, but on their own will not be suitable for preventing coronary events, especially in the acute setting, such as an acute coronary syndrome. And this is one aspect of care that really has undergone tremendous review of evidence through the years. Clinical trials, continuous revision of the consensus and guidelines from both the European and American side. And just in the last 2 years, several updates and guidelines have emerged, indeed providing us with the so-called state-of-the-art recommendations in the optimal strategy for this particular condition. The European Society of Cardiology updated guidelines was presented in the virtual ESC Congress from Amsterdam last year and published at the same time, while the ACC released their expert consensus pathway for antithrombotic therapy for patients with AF and acute coronary syndrome just this year. Now, we are in a time wherein scientific evidence is very rich for this particular dilemma. In the last 11 years, 4 trials on the NOACs plus an earlier trial looking at warfarin among patients with atrial fibrillation coming in for PCI and stenting, and including acute coronary syndrome with stable or those with stable coronary artery disease. Your WEST trial, which looked at a small number of patients randomized to warfarin triple therapy with aspirin clopidogrel versus dual therapy with clopidogrel only. Then you have your Pioneer AF-PCI, which looked at rivaroxaban antiplatelet dual therapy versus triple therapy using a lower dose rivaroxaban versus warfarin triple therapy. Then in 2017, the Redual PCI looked at 2 doses of dabigatran with clopidogrel dual therapy versus your conventional warfarin triple therapy. In 2019, your Augustus trial, which looked at apixaban, clopidogrel dual therapy versus apixaban triple therapy with aspirin clopidogrel versus warfarin dual therapy with clopidogrel and versus ultimately your warfarin triple therapy. And finally, your Entrust AF PCI, which looked at edoxaban dual therapy with clopidogrel versus warfarin triple therapy. These trials looked at safety endpoints of bleeding and secondary endpoints of cardiovascular events. And in a nutshell, the dual therapy, either with your warfarin plus clopidogrel or your NOAC plus clopidogrel, was associated with less bleeding events compared to warfarin triple therapy, while cardiovascular events, including your stroke, myocardial infarction, revascularization, stent thrombosis, were not that different. The message was that for atrial fibrillation patients with acute coronary syndrome needing PCI, dual therapy with an oral anticoagulant plus clopidogrel is associated with less bleeding, but no increase in stroke, myocardial infarction, and stent thrombosis. Now, applying all this evidence in the management of the patient with atrial fibrillation and acute coronary syndrome, it is always prudent to expect and be ready for the unexpected. Apply the science to achieve the best possible outcome for the patient. Build confidence and be confident in your treatment regimen. Use, apply, and trust the guidelines, but ultimately individualize your strategy to the clinical profile of your patient. Now, there are two clinical scenarios for this problem. The common setting is the patient with atrial fibrillation who is maintained on anticoagulant, now coming in with an acute coronary syndrome. And the other setting is a patient with acute coronary syndrome who is started on dual antiplatelet treatment, now developing new onset atrial fibrillation that requires anticoagulant. In any scenario, there are several guiding principles. In general, for patients with atrial fibrillation coming in with an ACS needing intervention, PCI, NOACs should be temporarily stopped. Your NOACs should preferably be discontinued for both elective and emergency interventions, and upon presentation with a non-ST segment elevation acute coronary syndrome, wherein early coronary angiogram is anticipated. In STEMI patients, PCI is preferred. This temporary discontinuation of the NOACs will allow safe initiation of your antiplatelet treatment, as well as your standard local anticoagulation practices peri-procedurally. The last dose of the NOAC should also be noted, as well as the adherence profile. And on the other hand, NOAC should be continued in non-invasively managed ACS patients. The treatment regimen thereafter must account the ischemic risk and bleeding risk, and this will now involve a balancing act, communication and coordination between you as the attending physician, the interventionist, the electrophysiologist if applicable, and the patient. If an anticoagulant is needed, as is frequently the case, a NOAC is preferred over warfarin. Now, a dual therapy regimen with an anticoagulant plus your P2Y12 inhibitor, preferably clopidogrel, is preferred over triple therapy. If a triple therapy is indicated and decided, the shortest possible time is recommended to decrease the risk for bleeding. The duration of this triple regimen may be adjusted based on the ischemic risk and the bleeding risk of the patient, with a high risk for thrombosis favoring prolonging the duration, while a high risk of bleeding, on the other hand, will favor shortening the duration of your triple therapy. The recommended P2Y12 inhibitor is clopidogrel because of its less bleeding complications compared to the newer drugs. If necessary, however, ticagrelor, which can be used especially for patients with complicated coronary lesions and high risk for stent thrombosis. This regimen has been used in some trials with caution. The guidelines discourage use of your prasugrel together with anticoagulant because of a more than 4 times risk for higher bleeding. Now, if your aspirin is used, do not use more than 100 milligram in terms of dosage. If warfarin is used, we need to target the lower INR range. In all regimen, we need to start a proton pump inhibitor, preferably, and avoid NSAIDs. For interventions, a radial access is recommended for obvious reasons. And in all cases, you need to individualize your approach according to the patient profile and preferences. Now, let us start with the first scenario, exemplified by this 68-year-old gentleman with atrial fibrillation and multiple comorbidities and a previous stroke. With a CHATS VAS score of 5, he's maintained on the Bigatron, now comes in with chest pain and is rushed to the ER. On immediate workup, an anterior ST segment elevation MI is diagnosed, and the cath lab is activated. With this clinical scenario, there is no doubt that this patient needs emergency PCI for the acute ST segment elevation MI. Now, the important questions are, how do we proceed? Is there any further testing indicated? Do we load with dual antiplatelet? Do we give the routine heparinization? How do we give the antithrombotic regimen after PCI? And what is the efficacy and safety of our particular strategy? Now, emergency PCI is indicated in ST segment elevation, MI, or high-risk non-ST elevation MI and unstable angina. In this patient, anticoagulant must be stopped immediately, and aspirin 160 to 320 milligram started. Now, there is an option to consider reversal agents when warranted, and in this situation, idarucizumab is recommended to reverse the effects of the Bigatron in patients undergoing intervention. Once the patient is in the cath lab, load preferably with clopidogrel 600 milligram, and heparinization may be initiated according to the ACS guidelines with either IV unfractionated heparin or low molecular weight heparin. The intervention is proceeded, and post-procedure, anticoagulation is started with preference for a NOAC over warfarin. Clopidogrel is continued, and aspirin 80 milligram is initiated. Now, if in this step, warfarin is warranted, we can start warfarin to target an INR of between 2 to 2.5. While initiating warfarin, make sure to keep your aspirin on until the INR is in target range. The standard regimen is a triple therapy of aspirin, clopidogrel, NOAC for 30 days, especially in high thrombotic and low bleeding risk. Then followed by clopidogrel plus NOAC maintenance until 1 year, after which only anticoagulant is recommended. For patients with high bleeding risk, the strategy can be individualized to shorten clopidogrel to 6 months. Some of the guiding points is that if a patient is previously already on a NOAC, then continue the same NOAC after PCI plus a P2Y12 inhibitor, preferably your clopidogrel. If in case the previous anticoagulant is warfarin, there are two options. We can reinitiate the same warfarin post-PCI, or if the patient is eligible for clinical criteria, preferably shift to a NOAC, unless, of course, there's a true indication for warfarin. Now, a subplot to this scenario would be the STEMI patient that opts for fibrinolytic therapy or refuses PCI. Now, the added dilemma here is that thrombolytic therapy may be associated with an increased risk of bleeding in systemically anticoagulated patients, especially if intravenous heparin and antiplatelet drugs are to be given. Balance between the potential benefit, that is when you have a large anterior myocardial infarction, and harm, the risk of intracranial hemorrhage, is needed to be done in this particular situation. Now, actions will involve stopping the anticoagulation, as well as reassessment of the urgent transfer to a PCI center. Now, in any case the patient really goes for thrombolytics, the anticoagulation status must be assessed. Knowledge of the last dose must be taken, as this will give us an approximate idea. For your warfarin-treated patients, you get the INR, while for the Bigatron-treated patient, we can assess through the APTT. Unfortunately, for your factor 10A inhibitors, the anti-factor 10A level is the gauge, and this is not available widely. If your INR is less than 2 for warfarin, or the APTT is normal for the Bigatron-treated patients, then thrombolytic therapy may proceed with caution, and IV heparinization may be instituted. Finally, post-thrombolytic, Antithrombotic treatment will consist of clopidogrel 6 months to 1 year plus anticoagulant, preferably a NOAC, indefinitely. A second scenario is the patient with an acute coronary syndrome who develops atrial fibrillation. This is a 72-year-old female with multiple risk factors, presenting with chest pain and diagnosed with acute non-ST segment elevation myocardial infarction. The echo showed an LVEF of 40%, and she undergoes coronary angiography as part of the early conservative strategy and undergoes PTCA with stenting of the LAD coronary artery. Now, subsequently, dual antiplatelet regimen of aspirin and clopidogrel is initiated. On day 2, she develops atrial fibrillation, which persists. And so, with the cited comorbidities, her CHA2DS2-VASc score is 6, equating to a very high risk for stroke. There is therefore no question that this patient needs an anticoagulant. Now, the key issues are the following. How do we proceed with the antithrombotic regimen? What will be the efficacy and safety of this strategy? The first critical action is to rule out the need for warfarin. Hence, assess if the patient has moderate to severe mitral stenosis. Of course, if a prosthetic heart valve is present, that should have been known on admission, as both situations will warrant warfarin. If none, then we assess the CHA2DS2-VASc score. And men with a score of 2 and women with a score of 3 will need an anticoagulant, preferably a NOAC. Take note that a patient with acute coronary syndrome automatically has a score of 1 for vascular disease. And add to this the scores associated with comorbidities like hypertension, diabetes, the age, the heart failure, which are almost always present. Then we assess the bleeding risk, and we have several scores to choose from, for which the HAS-BLED is the easily and widely used scoring system. We need to remember, though, that the assessment of the bleeding risk does not defer us from giving the anticoagulant, but warrants us to correct the factors associated with the bleeding risk and monitor these factors closely. It also mandates us to discuss these risks with the patient and the family in order to come up with the best shared decision for the patient. Now, in all indications, anticoagulation is needed and should be started. And there's again the preference for a NOAC if the patient is eligible. The next decision will now be what to do with the dual antiplatelet. The expert decision pathway recommends to stop the aspirin, continue the P2Y12 inhibitor clopidogrel. Now, this decision is individualized based on the patient profile. High thrombotic risk and low bleeding risk patients may continue triple therapy regimen for 1 month, followed by a dual therapy regimen for 1 year. On the other hand, high bleeding risk and low thrombotic risk patients may shorten the duration of the antiplatelets. Finally, for those with high thrombotic risk by nature of the coronary lesions and the clinical profile, may continue your dual therapy of clopidogrel and a NOAC beyond the 1-year treatment period. In other cases, clopidogrel is stopped in 1 year and the NOAC is continued indefinitely. This sums up the management strategy for patients with atrial fibrillation and acute coronary syndrome. The default strategy after PCI is triple therapy with aspirin, a P2Y12 inhibitor, preferably clopidogrel, and a NOAC for 1 month, followed by dual therapy with clopidogrel and NOAC up to 1 year. Then long-term single therapy with a NOAC. Depending on the patient's clinical profile, coronary anatomy, your thrombotic risk and bleeding risk, the duration of triple therapy, and subsequent dual therapy may be adjusted. High thrombotic risk and low bleeding risk may allow you to increase duration of the aspirin to 3 to 6 months. On the other hand, high bleeding risk and low thrombotic risk can allow you to bring down the clopidogrel to less than a year. Now, for ACS patients managed medically without PCI, the strategy is a dual therapy with clopidogrel and a NOAC for 6 months, followed by single NOAC therapy long-term, with the option to prolong clopidogrel treatment depending on the individual risks. The figure at the bottom is for chronic coronary syndrome patients, and briefly, after PCI, triple therapy is recommended for 1 month, then dual therapy with clopidogrel and NOAC for 6 months, followed by single NOAC therapy as maintenance. The management of these patients, of course, go beyond just the antithrombotic treatment. Other aspects also need to be addressed, and these are also covered in the updated guidelines. First, urgent direct current cardioversion is appropriate for patients with acute coronary syndrome with new onset atrial fibrillation and intractable ischemia, as well as those with hemodynamic instability and inadequate rate control. Intravenous beta blockers for rate control is recommended to reduce myocardial demand, while your intravenous amiodarone is given as a class 2B indication, appropriate alternative for rate control, and may actually facilitate conversion of the AF to sinus rhythm. Other drugs like your non-dihydropyridine, calcium channel blockers for rate control in the absence of heart failure or hemodynamic instability, as well as your digoxin, are also considered. I leave you with the following key messages. In the management of atrial fibrillation and acute coronary syndrome, hope for the best but expect the worst. Optimize your anti-ischemic and stroke prevention treatment, but be cautious of the bleeding complications. Managing these patients will be a continuous balancing act of weighing the benefit of stroke and myocardial infarction prevention and the risk of bleeding. Choose the strategy with the best possible outcomes in both efficacy and safety. You want the best outcomes in prevention of stroke, MI, stent thrombosis, revascularization, and cardiovascular death with the less bleeding complications. Next is plan your treatment. What anticoagulant to use? What antiplatelets to use? The length of your triple therapy, the length of the subsequent dual therapy, the backup plan in case adverse events happen. Be flexible in adjusting your strategy to the profile of the patient. Finally, use the evidence and your best experience. The guidelines are a conglomeration of the best available evidence. Be guided by them, but always cater your management to your individual patient. This is my concluding message of hope to all of you. And there are definitely better days ahead, and I look forward to seeing you all face to face when the dust settles. For now, I wish you all to stay safe and strong, and a pleasant day to everyone.